A warm welcome to you from Geneva, Switzerland. I'm Rida Sadki from the Geneva Learning Foundation. This is part of a series of experience sharing sessions, but it's the first one that is intended to help you with the development of your Immunization Agenda 2030 action plan. So we're here together. We intend this to be a small group discussion even though it is open to all, in which we will focus on one person's action plan and then invite everyone in the room to share their experience with respect to specific priority challenge, the goal, and corrective actions of that person's action plan. So the first thing I'm going to ask for is a volunteer. You can volunteer by going to the reactions in the which is a little Zoom option. You should see a smiley face and then choosing raise hand. And for that, of course, we'll start by asking you the questions we worked on yesterday in the assembly, but this time we'll be able to we'll deep dive into them. What is your priority challenge? What will be the goal or the objective of your action plan? And then really looking at you to summarize all three corrective actions, and then to tell us which of these indicators you consider important and why with respect to your action plan. That is the important question. I will also show you that for those of you who have not yet gotten to it, and that is going to be my first question, you received the personalized link to access your action plan questionnaire yesterday, right after the assembly. So do look for it in your inbox. And I'm going to ask you to type yes if you have at least clicked on the link and accessed the action plan hackathon questionnaire. So if you have not done so, then type no. So yes, if you have seen the screen with your name on it that you see here, and no, if you haven't seen. Okay, Hassan Benya, you haven't been there yet. So I urge you to go to your inbox, find the email that has that. Adesochi Olatunda has not seen it yet. So of course you'll see your name on it if you use the personalized link. But I see that many of you who are here, and so, all right, Professor Becky Tagbo, you have until May 20th, which may seem very far, but I can tell you it's going to come very quickly. So, all right, Samuel Ajansan Sule has seen it. And I know some of you, we've already received around 40 action plans from the Anglophones. Take your time to think through it, but get it done. So if you're short on time, it may be good to just go through it, do the best that you can. You can always improve, revise. It is not being graded. It is not going into peer review. It is an action plan that you do for you. So, make the best of it to get the greatest benefits. So all right. So now we need a volunteer. So please raise your hand. Otherwise, we will volunteer you. We will volunteer someone in the room. If there is no one who spontaneously volunteers, if you were diligent enough to actually come to this session, we believe it must be if you will. Because you are determined to develop your IA 2030 action plan. So I urge you to raise your hand. Otherwise, we will have to designate a volunteer. All right, Daniel Kwesi Ekwam, we will keep you. I appreciate you being the first to raise your hand. I will say that we'd like to ask to prioritize those of you who are new to the movement. If you have received the link for the action plan and you understand what the questions are, you weren't completely lost yesterday, and you're following along, appreciate Danielle's offer of service. And Danielle, what we'll do is, if we have a new volunteer who's just joined the movement, we'll ask you to give them feedback and to share your experience. So I can't believe that out of a group of 52 members of the IA 2030 movement, there's only one person who is interested in sharing their experience. We may as well close the session right away if no one is willing to share. And Iwat, of course, you are a longtime member and a leader in the IA2030 movement community. I would like to ask really to call on you and Daniel to share your experience and to really provide the opportunity for someone who's completely new to the movement to share their experience. So what you need to do is find the reactions and then click on the little smiley face to share your, to raise your hand, as Daniel and Dayo Iwat have done. Melissa Teferi, I see you have opened your microphone. Are you ready to share your action plan?
Yeah, hello, Rada.
Yes, Melissa. Yes.
Yeah, thank you to give me the chance to just share my experience and to just introduce my action plan. I'm actually in just a busy environment in my organization, and I lose some of the sessions that are really important for me. But now I am happy to rejoin you and try to share my challenge. So my name is Mohameds from Ethiopia. I'm a researcher in Mohameds Research Institute. It's under the Ministry of Health and mainly focus on child health and immunization programs. I'm really working in vaccine-related research, especially COVID vaccine effectiveness trial is conducted in Ethiopia, and I'm one of the co-investigators. So as a challenge, the main challenge, especially in this during the pandemic period in Ethiopia, is really there's a huge zero-dose children and disadvantaged populations that need the service to be rejoined or to resume to the previous, at least to the previous level. So high zero-dose populations are available in Ethiopia, especially in rural populations. That is really difficult to address by using routine healthcare activities. So it needs my objective is to address this group of the population to have or to get the routine immunization activities by different mechanisms using just like using just mobilizing the community to come to the healthcare facilities, to bring the service to the community by outreach programs, and also just to give attention for those populations who already missed the first as well as second and third level of immunization programs. So my corrective action that I try to implement to address this community is that I need to integrate the COVID-related activities with routine immunization programs and in mobilizing the community as well as in giving the services and using the resources even. Mostly the healthcare professionals were focused more commonly in COVID activities, but it should be incorporate the routine immunization with the COVID immunization program or COVID immunization activities. We need just integrate the routine immunization with the current emerging prevention activities. So integrating the resources, the logistics, as well as the human resources and the financial resources is very important to address these zero-dose children, especially using by just different ways to address that. For example, there should be but really focused to address. There should be a team that will be organized to address this group of community for specifically short period of time and bring them to the normal routine activities. So it's very important to, I think this is, if you have any question, I can just try to address.
I have lots of questions. I'm sure François and also. Before we do that, let's hear a second challenge. So we had Josephine Okide, so we can and then for every other member of the movement who hasn't spoken yet, you just heard Melese Teferi describe his challenge of reaching zero-dose children. Josephine, are you able to unmute? I'm asking you to unmute if you are able to hear us. We'd love to hear you share as well. You again want to invite new members to the movement, women, and people who haven't spoken before more generally. Josephine, welcome.
Thank you so much. I'm not really a new member, but I can share my experience.
Yes, please. Yes, so either you can respond already to Melese Teferi's zero-dose case, or you can tell us about your own challenge and corrective actions.
Okay, probably I missed what he said, but I can share my own experience. Probably he might learn from it. Okay, the challenge is still the same challenge of reaching zero-dose children. I know I did my situation analysis on the same topic, and then I have my objectives. I have two major objectives. One is reaching 80% of children who have not received zero-dose vaccination in Borno State. And then the second objective is to identify innovative ways and means of reaching children with zero-dose vaccination in inaccessible locations. These are the two major objectives I have for the action plan. And then one of the corrective measures is to conduct integrated outreach session.
Yep.
Hello, can you hear me?
Yes, very well.
Can you tell us the other two corrective actions that you've listed or will list in your action plan?
If you remember during the situation analysis, I mentioned the hit and run strategy. So it's another corrective action because some places where we work are security compromised. So we work with the military to do the hit and run strategy. So one of the corrective actions here is to intensify this strategy. And then the third corrective action is to adjust immunization schedule. And one of the findings during the situation analysis was that during the normal immunization schedule, some parents and caregivers are not at home because of some other priorities, like going to the farm, going to the market. So one of the corrective actions here is to discuss, have a community dialogue to find out when it is suitable for the community, when they are mostly at home, know their characteristics, and then schedule the immunization to reach those children who have been missed with zero-dose vaccination. So these are the three corrective actions.
Is it possible to ask a question, Rada? Sorry.
Sorry?
Yes, Melese, go ahead.
Okay, go ahead, please.
Yeah, thank you for your presentation. I need to have just a clarification.
Yes.
To reach 80% of zero-dose children.
Yes.
In your action plan.
Yes.
What is your denominator? Where is your base to just develop this 80% of?
Okay. During the situation,
did you have any Maybe that's clear. That need to be clear for others also. Yeah.
Yes. Okay. During the situation analysis, it was found out that 61% of the children in Borno State have been reached with Penta-1 vaccination. And so 39% of them have not received. And this 39% is about 600,000 children. And so during this action plan, I plan to reach 80% of the 600,000 children. So that is how the 80% came about, because I know it may not be really possible to reach 100%. So I'm aiming at 80%.
So you going to improve the current zero dose level to 80%, or you just cover the zero dose children's about 80% of
the missed children, reaching 80% of the missed children.
Oh, okay, good.
Thank you both, Melissa and Josephine. So let me remind you how we're going to proceed now. So first of all, we are opening up the experience sharing. So please raise your hand if and only if you have experience specific to the two action plans you've heard summarized. So if in your experience you have done something that has worked, or maybe something that has not worked in relation to reaching zero dose children, and even more specifically, zero dose children in conflict areas.
Exactly.
With those strategies, we want to hear from you, and we need you to raise your hand so that we can unmute your microphone. So that is the first step. After we've heard the first set of experiences shared, we'll turn to François Gasse, who will probably have additional questions. If no one is, as I see, no one is, okay, I see one hand raised from Mohamed Ali Ugafa. So after we've heard a couple of experiences, we'll go to François for him to ask both clarification questions and further questions to keep us digging at the experience sharing so that we come away with something that is useful. Now, this is going to go very quickly because at the 30-minute mark, as you remember, this is a 30-minute session. However, given the level of interest, with François, we will offer to stay longer, to stay above and beyond, and we will ask you, so if you need to leave at the half-hour mark, you will leave. You will be able to go back to your daily duties, whatever you're supposed to be doing at this time. But if you'd like to go deeper into the experience sharing, we will extend the session in order to share, but we'll extend only if you want to. So I'll be asking you if you want to the chat. So we have two contributions. We have Mohamed Ali Ugafai and then Sunil Raja. Please raise your hand. Go to reactions. That is where you find the hand raised icon. All right, I think I'm going to have to put, all right. Yes, so Mohamed Ali Ugafai and Sunil Raja, I'm asking you to unmute. Both your hands are raised, but I'm not, yes, okay, Sunil, yes, what is the specific experience you'd like to share that is going to help your colleagues with respect to reaching zero-dose children and specifically in context areas? Sunil, don't forget to introduce yourself, tell us who you are, where you work, before sharing your experience.
Yes, I think, am I audible?
Loud and clear.
Thank you. So thank you so much, Reda and Dr. François. And the presentation shared by our colleague is really wonderful and they have good idea. Now I would like to specifically focus on the, like we can say that is, we need to have smart plan. Smart is a specific, measurable, accurate, and time bound. So I'm going to share the experience how here in Pakistan, in Sindh, we are focusing the zero dose. So zero dose is basically in our province and the country is being reported by polio teams. When they go in SIA house to house, they collect the information of the zero dose. So once the SIA campaign is over, they share data to their data support center, which is they make the computerized the tally sheet hard copies of the tally sheet into the computerized form. Then this data goes to the provincial office, and again it will be shared with the polio team, and the EOC team will share with the EPI. Now what happening, once the provincial office EPI receive the data, they again share to the district and the union council level. So we are thinking that we need to do something, like if data is reported from the community at the UC level, from the polio team, vaccination team is already there, like vaccinator and lady health workers we are using here to cover the 0 dose. So they are already there. The first step that we are focusing, that data should not go to the higher level and then they come down to the again UC level staff. So when the polio campaign is over, the data directly should be shared with the at the same union council level or health facility level, where both polio team and the vaccination team are already there. This is one strategy. Second, what we are doing, we need to more strategize, like the vaccine that is available BCG is in the multi-dose vial. This is another challenge, like if vaccinator found 0 dose children in the scattered or remote area, one at one place and one at other place. So again, it will be challenging how he is going to minimize the wastage rate, because there is a pressure that wastage should not be more than 50%. So this is another challenge for the vaccinator. If we give him the list of 0 dose children with the complete details, but again, he has same challenge. Now what to do? We have community vaccination teams, like the lady health workers are there and the polio teams are there. So now we are going to target this, and we are strategize this policy that when 0 dose list is available with the vaccinator, he should be contact to the community, to the lady health workers, to the polio team, 3-4 tiers of the community he should contact, and he should focus that where he need to go and prioritize, so that he can cover in the cluster form, like he can maximize the number of 0 dose. And in some areas where vaccinator is unable to go, we are initiating other activities, like we have now started the mobile vaccination van. That is only for the area where vaccinator feels unable to go, because van can move easily from one cluster of village or area to another. So this is another form. So I think now we are the outcome and the point that I am emphasizing and I wanted to share is we need to strategize the coordination more in an effective way, so that data sharing should not be delayed. It should not be rolled out through the different channels. It should be directly, and it should be timely. And all actors that are in the community, from the polio and the routine immunization, they should be well coordinated. Must be coordinated very in an effective way. So the meetings and the coordination, that is the main challenge for us here. We are struggling with, and we are making strategies to cover. So I think this is the small my comments. So thank you so much, and definitely I would like to listen more comments from other colleagues, and maybe I will be explaining, and I may be commenting later on if I think that it's needed. Thank you so much.
Thank you, Sunil. Raja, the point about data guided, which is key to Immunization Agenda 2030, is well taken. Boma Otobo, and then we will. Yeah, I just took note of Amalu Shifra, but Boma, let me ask you to unmute.
You didn't carry the pounded yam now. Hello.
Yes,
hello, thank you, Radha. Can you hear me?
So Amsalu, we're going to listen to Boma Otobo first, and then we'll come to you next.
Hello, Reda. Good evening, and good evening to everyone on the call. And thanks for the opportunity to speak on this challenge. Mine is equally with regards to 0 dose children in our communities. So the objective is to reduce the 0 dose children in 145 prioritized LGAs. And these are scattered across 29 states in the country, talking about Nigeria. I'm sorry I didn't introduce myself. My name is Boma Otobo. I recently retired from the National Primary Healthcare Development Agency. but still actively involved in immunization. And thanks to Dr. Reda for keeping me on course in this area. Yeah, so please, can you go back to the other slide? Okay.
So
Yes.
what we're looking for is really your specific experience in reaching zero dose children to help the two colleagues who shared their zero dose challenge, including one who is in Nigeria and focused on zero dose in conflict areas.
Okay, yes. So like I said, the 145 LGs, we have 80 of them that are not in conflict areas, but we have the other 65, which are in security compromised areas and very hard to reach. You know, like the conflict in Nigeria, in some of the states, it's quite fluid, but we have mainly in the northwest, northeastern states. And quite recently, we have the southeastern state also experiencing some level of disruption in services. So we have the zero dose children scattered across. Some are even in the urban areas, like some comments have also shown. We've done something like this, an action like this in the past. What we did in recent past, which was about December last year, was to get together all the states where we have this highest burden of the zero dose children, had an engagement with them, and they in turn will go back and develop what we call the zero dose reduction operational plan. And with that plan, they will be able to carry out the outreaches to ensure that those children are covered. So who will carry out this action? We have the state immunization officers driving the process, or the program managers at the SERIC. SERIC is the State Emergency Routine Immunization Coordination Center. And we also have the LIOs, the local immunization officers at the LGA level, and they will also be assisted by the routine immunization officers. How long will it take? Yeah, we have commenced in some of the states, and for funding reasons, I think some states are yet to commence. So we're looking at minimum of 3 months, and I will explain why. The 3 months is because of the strategies we're about to use. For instance, we intend to use well, sorry, not about to use, we're already deploying in some of the states. So for one, we use the RI intensification, routinization intensification, and we need to do those for 3 months so that we can see what the number of children that are being reached in those 3 months, and then we can compare with other past plans. We also have the OIRIS, the Optimized Integrated Routinization Sessions, which is also now being integrated with RMN, that's the Reproductive Maternal Child Adolescent Health and Nutrition programs. Then we also have the strategy where we intend to optimize the sessions. For instance, we ensure that every tertiary, secondary, and urban health facilities should conduct daily immunization services, while the rural areas at least once a week. For the new vaccine introductions, we also intend to reach the zero dose populations through that. And the last I would want to mention here is the expanded engagement meeting with the states, the sub-national level, also bringing in other program officers. Looking at all of this, we intend that these programs are integrated. We don't want to carry out standalone activities. So we integrate with the polio, the non-polio activities, the campaigns that are ongoing. So all of this are happening. And how will we know if we have succeeded in this action? Yes, so the indicators we're going to use to monitor, which we're already deploying, will tell us how well the LGAs are performing, and even up to the state level. So that would tell us when we have succeeded, when we begin to see a reduction in the number of children that have been vaccinated, and also a reduction in the number of outbreaks, because we all know that if immunization is poor in any area, then of course we're setting ourselves up for an outbreak. So I think I will stop at this point. Over to you, Reda. Thank you.
Thank you, Boma-Otobo. Now we are at the 30-minute mark, so some of you may need to go back to your duties because this is a 30-minute session. However, in order, if only to hear François Gasse's questions and reflections and his experience on the first two challenges that we heard from Josephine Okide and from Elise Teferi, both of them on reaching zero-dose children, I'm going to ask you to confirm that you'd like this session to continue. So, of course, if you need to go back to your duties, please do so. But if you'd like this session to continue, type continue or just type yes into the chat. If there are no yeses or very few of them, then we shall bring this session to an end. All right. Samuel Fetene, Deborah Tembo, Ibrahim Abdullahi. So this is a kind of ritual of the experience sharing sessions because this experience sharing is not mandatory in any way, shape, or form. If you choose to participate, you come. If you choose not to participate and not benefit from experience sharing, that is your decision. But we believe those who participate, we see them consistently doing better than those who do not. All right, François, over to you now. There was a lot that we heard from both the initial presenters and then the contributions we've heard so far. What are your specific questions, follow-up for Josephine, Melissa, or others? And what are your reflections, your experience so far?
Thank you, Reda. I think it was a very rich presentation by Melissa, Sunil, and the comment and the last Mrs. Otobo from Nigeria. And it's very rich, and it's I think they addressed a very concrete challenge and an objective and the way to do better, and for some to monitor how well they do. I think what I've written, because I think I don't have many questions, I can just highlight some of, I feel, are very key points raised by the experience sharing. And for me, what I noted from Melissa, and I really appreciate because not many people are doing it, is in the seat analysis, they really look at how many zero dose. She found a way to set an objective, and as it was questioned, she responded very well on how she wants to reduce by 80% the zero dose. And of course, this is a very, very concrete, and we hope that all situation analysis can lead in zero dose to such very specific figures quantified with evidence. And we know the challenge. I think it was very interesting that she said that to correct she needed an integrated outreach session, and we have seen the word integration repeated by the successive sharing of experience. Integrated outreach, integrated COVID and route immunization together to optimize resource made available, integrated with other intervention, life-saving intervention. These are very, very concrete. We have heard also the need to respect in those remote community, you need outreach and you need to respect the priorities and dialogue to get the best opportunity to immunize. This is convenient for the communities through a dialogue and not assume everybody will come when you go there. So to ensure the quality of the outreach, running outreach is one thing, it's offering service. Quality outreach is another challenge. I would say I really appreciated the link again. It's a link of integration approach between polio, who identify zero dose, and use this identification at local level, does not go through the bureaucratic process. I think Sunil has a very great idea to decentralize the use of such information between EPI and the polio and try to correct the issue on the spot. And I think it's a very, very nice, innovative idea to do that. And I would say that the last one is maybe the routine intensification. We all know that with the pandemic, there's been a deviation of focus of attention on introducing vaccine COVID, and it has to be revert. Outbreaks of measles everywhere. reflect a drop in the intensity of the service offered because of the pandemic, and it's time to reconnect and revamp the routinization coverage. And I particularly appreciated that there was the monitoring to make sure that what you do makes a difference and looking at data. The reducing the zero dose, I think in some countries, my experience, they use, if you see an increase in the number of penta-1, you know that you're reducing the zero dose by default when you don't know the exact size of population. And I would say the things I would like to stress at the end, the stress is on zero dose. Make sure we're not reaching the zero dose with only one dose. They need many doses to be completed, vaccinated in all the series. So I hope the zero dose does not put a low emphasis on the continuity that all children catch with zero dose will have the service offered to receive the other dose they need to complete immunization. So thank you. It was very rich information and very useful. And the vaccine wastage is an important issue, and you have to adjust the policies that you want to reduce wastage as a minimal. And I think priority, the word I heard was prioritizing the area of clustering a zero dose to optimize the wastage rate. So thank you for all this information. I think it's a very rich session. Yes, thank you.
Thank you, François. Let's go to Assad Ali. And before we do, while Assad is unmuting, I want to highlight Magaji Garba Adamu shared his experience saying we introduce missed opportunity tracking of zero dose and partially immunized children. We did this when the child is brought to the hospital for other illnesses. From there, we ask the immunization status of the child. If he is zero dose or partially immunized, we immunize the child and book him for a next appointment. A very concrete illustration of a practical strategy. Assad Ali, I'm asking you to unmute, but I do not see, you do not seem to be, okay, Assad, don't forget to introduce yourself. Some of you have jumped in with your ideas and have forgotten to tell us who you are, where you work, what country you're from. So please start there, Assad Ali.
Hello, good evening to everyone. I'm Dr. Assad Ali and working as technical consultant for routine immunization in one of the provinces of Khyber Pakhtunkhwa. So it is basically I'm working on a subnational level. Challenges in API. Of course, in Pakistan, from Pakistani context, I would just like to say that we have got a lot of challenges, and prioritizing among those challenges is also one big problem for me personally. However, today I will mention the problem that we are trying to tackle, and it is the same zero dose. So initially what we did was that in Pakistan, unfortunately, we have got one of the very few countries which is endemic with polio. And we just recently, last month, we received 2 polio cases from one of the very volatile districts of Khyber Pakhtunkhwa, which is Waziristan. So we have got this zero dose problem all across KP, but with specific emphasis on south of our province. So the way we are dealing with this is, so initially what we did was, since we are having 2 programs carrying on in Pakistan, one is EPI, expanded program on immunization, which is taking care of the routine immunization, and then we have a polio eradication program as well. They go sidewise in parallel, and but our national priority at this point in time is polio eradication. So we were using basically 2 different definitions of, and we are still using 2 different definitions of zero dose. In all the discussions that we heard, unfortunately, I could not hear anything about the definition of the zero dose. When we did the research, we found out that Gavi thinks that zero dose is the child who has not received any vaccine from birth until 2 years of age. Whereas, sorry, this is the polio definition of zero dose. And the Gavi says that any child who misses first dose of Penta-1 vaccine will be considered as a zero dose child. Zero dose child. So what we did was, then we went for the polio definition, and we wanted to address that concern first. So what we did was, we basically adopted multiple strategies, right? So one of the strategies was presented by our friend from Sindh, whose name was Sunil, and he explained it very well, that when the zero-dose children are reported, they are immediately covered by the vaccinators. But unfortunately, the problem is that during the catch-up days, immediately after the campaign, the problem is that we can only cover 20 to 30% of the zero-dose children in my province. I'm not talking about any other province. So we realized that immediately after the campaign, it is probably not possible for the teams to again sweep the area and cover all the zero-dose kids. So we developed multiple pronged strategy for it. So we are now relying on 3 main strategies. So one is, I would like to mention, and which indeed is very close to my heart, that we should prevent, so any child who is born in a facility should not go unvaccinated. So what we did was, we did an exercise in the whole province. We found out the hospitals where there were deliveries happening 24/7, but unfortunately the vaccination teams were not available on 24/7 basis. So what we did was, we did a kind of a survey through our health teams. We found out the number of deliveries per hospital, and then we developed the criteria that any hospital with 10 or more than 10 deliveries should have a 24/7 vaccination team available who can vaccinate the child right at that point in time. And we call it as a birth dose initiative. So what we did just recently, like a month ago, we did was, we shortlisted 50 hospitals where deliveries are happening, and we deputed, so the morning teams were already there. The problem was with the remaining 3 shifts, like the afternoon, the evening, and the night. So we deployed teams in those shifts as well. So now what we are trying to do is prevent the zero-dose children from occurring. It's like sort of, you nip the evil in the bud, right? So any child who is born, just vaccinate him, and don't let this become as a missed opportunity. So one is this strategy. The second strategy is that we are trying to strengthen our outreach activities, and also synergizing the PEI, the polio eradication, and the EPI programs as well. So the data is collected from the PEI, and the EPI tries to cover those children during their outreach sessions. And what we are trying to impress upon the vaccinators is that we are asking the PEI teams to make available the list of the zero-dose children with all the EPI teams, so that they can find them in the field, then during the routine outreach activities. Then we are also seeking help from the polio program through mobilization of those zero-dose children, so that they can be mobilized and referred to the outreach points. This is another strategy that we are trying to strengthen, and in fact it is happening as well. Then the third is slightly out of the ambit of EPI, but we are actually also coordinating with the health department, and especially with the security compromised areas, that we should have health camps in those areas. This is an experience which probably came from Nigeria, but it is also very, very practical. We used it in Peshawar, we used it in, and now we are using it in the south of AP, which are security compromised areas. Over there, we are trying to do the health camps, and then we are using the same methodology, that by mobilizing the priority children, we call them basically priority children, to come to the health camp sessions or to the outreach sessions. The first I told you that we are strengthening the hospitals so that they can provide the vaccinations right at the time of delivery. So this is from my side, and but I would like to say that there are many, many more challenges. For example, one challenge that right now we are facing is fake finger marking, but we are trying to find out solutions that how can we go about it, and how can we prevent the fake finger marking. And but that issue probably, once we come out with potential solutions for it, and once we implement it, and if it comes to if it is successful, then we will present it here. So over from my side, and thank you so much, Rita, and everyone, for patiently listening to me and giving me the opportunity to speak on this. Thank you so much.
Thank you, Assad Ali. Before we go to François, I want to highlight, because those who watch the recording will not be able to see the chat, there have been some very interesting contributions in the chat. I'm going to try to highlight some, if not all of them. Ndayo Iwat, who says, bridging human resource gap to improve immunization supply side by engaging volunteers short term and absorbing them as pensionable personnel in the long term. So as a strategy or action. Raul Bonifacio, says, in addition to the above and interventions by 3 colleagues to cover zero dose, it is essential, says Raul, to identify the population who are at high risk or zero dose could be at risk, and it must be assessed at the smallest level, the village. Magaji Garba Adamus adds, we developed this and carry out with the use of voluntary community mobilizers, so VCMs sponsored by UNICEF. Ibrahim Abdullahi Maikano from Afinet CDC says reactive measles vaccination integrated with all antigen, including COVID-19 vaccines. And Dayo Iwat adds the community scorecard operationalization by community leader by monthly update shows where newborns are by number and dates every month in the community. This helps control zero dose children as babies born outside health facilities are easily identified and vaccinated. Martin Izayama says, I can see you, but not hearing your voices. For zero dose and under-immunized in conflict areas, we dialogue with Eze of the community and mobilizers to security assign the community to protect us while we vaccinate the children seen. They allowed us, but mothers are afraid of coming out with their children. Magaji adds the VCMs are mature females selected from the community and they entered H2H for community mobilization. And then Sikru Buhari from Nigeria says, I try to institute monitoring of zero dose using the surveillance network when conducting investigation of reported cases, AFP in particular. The DSNOs conduct surveys of 10 children under 2 years to know their vaccination status. Atahir Abubakar, again, Nigeria, we use traditional birth attendants to track zero dose in rural areas. They go along with their vaccine carriers when they identify zero dose during naming ceremonies or weddings. They give the child OPV and link him with a health facility nearby, then keep track of the child until completion. Oladipo, sorry, I just think these are important enough to read because I know if we try to give voice to every person, it would take even longer. I'm hoping, I'm going to stop soon because there's too many great suggestions, which is a nice problem to have. Oladipo Dapojo says integrated services at both fixed facilities and outreach sites help to dropout rates, pick up missed children. Mariam Idris, the experience I have in meeting zero dose cases and missed opportunities vaccine is that I encourage my facility to build an annex of immunization unit attached to the labor ward so that mothers after delivery have babies immunized immediately before discharge. Fixed post is mounted in strategic area of the community to address cases of zero dose and under immunized by community mobilization. This is Mariama Idris from Kano, Nigeria. All right, I'm going to stop here. We'll try, I can see there are many more. I'm going to check if there are, we already had several people with hands raised. So let's go to, Panmwa Mwatunwa. I'm sorry if I, and then we'll go back to François. So Panmwa Mwatunwa. I hope you'll correct if I'm mispronouncing your name. I'm asking you to unmute. Otherwise, let's go to Amsalou Shifra. Sorry to keep you waiting, Amsalou. I know you have been. Panmwa, please go ahead. What is the experience you'd like to share that will help your colleagues in developing strategies and corrective actions to reach zero dose?
About we have the alliance and grandparents and the Mamuna Ara intensification.
Okay. Yeah. All right, François, there's a lot there. And I know reading the comments is a little tedious, but it's probably more efficient than trying to hear from each person. What are your thoughts? If you were to advise the folks, and I think it's more than half of you have said that zero dose is important where you work, that you're concerned about the children that you're not reaching. François, what advice and what experience would you share?
One thing that's come out very clearly, that prioritization, given the competitive activities that exist between polio, campaign on measles, routine immunization, and others, I think prioritization to get the zero dose is becoming an important issue. And that's the way to make the first step, maybe not covering everyone, but when there are resource constraints, prioritization will help you. You cannot disperse a few teams to catch 1 or 2 zero dose. My second point was what maybe worried me is that if, he raised an important point, was the definition. If a child does not receive Penta-1, is a 0 dose. What maybe concern me and something to think about is when you catch a child in an hospital, it will be BCG because the child will only stay 2 hours or 2 days in the best situation and go. Now I'm concerned not to see a strategy to make sure that the child which was 0 dose is followed up for the next dose. What is the approach to follow that child and to complete his immunization? We don't want a big improvement in reaching Penta-1 dose, the first dose, and suddenly a big dropout in default numbers because we don't catch them again. The second point, when I heard about the strategy on hospitals, I was wondering, in some countries I visited, the private sector plays a big role in delivery, and they can play up to 20% of the deliveries. So my question would have been to the person in Pakistan who presented, how do you deal with private delivery? Are the private sector delivering doses of vaccine as well or not? And is there a policy for it that's in place or not? In many countries, in the hard to reach areas, there's no hospital. So there will be other strategies, but where your hospital, I've discovered in some countries that even in rural areas, you may have a private sector that immunize 20% of the children who may become 0 dose if they are not authorized to vaccinate. So what's the situation in Pakistan about it?
Let's see if we can go back to, okay, it looks like, yeah, let me see.
It's pas moi.
Yeah, Matuna. All right, let's see if Panwa is still here. Go ahead and unmute. I'm asking you to unmute. And then.
Yes.
Yes, go ahead.
Okay. Panwa Ubona from Nigeria. Hello?
No, sorry, it was in Pakistan. So I'm making a mistake on the name.
Yeah. All right. Okay. It looks like Josephine, unfortunately, is gone from the room. Let's see if we can go to Melissa. Melissa Teferi. You've heard a lot of comments and experiences shared by your colleagues. I'm not sure if we're going to try to get an answer about Pakistan, François, but Melissa, from what you heard, and you can say no. Is there anything that you heard in the experiences being shared that are useful to you, developing and developing your action plan to reach 0 dose in Ethiopia?
Yeah, actually in Ethiopia there are actually different problems. Have you heard me?
Yes.
Yeah, in Ethiopia actually there are different problems that may be cause for the current low coverage of immunization or high disadvantaged populations or high 0 dose children. So there is actually a war in eastern part of Ethiopia. That also one thing that contributes for the current problem in immunization program. And second, this is the pandemic problem, that is COVID. During the pandemic or during this COVID period, most of the health services, especially at the beginning, there was actually closing. Even the population were not come to the health facility to just get the routine healthcare practice, the healthcare activities like immunization, maternal care, and even other services also. So this lead to low coverage of immunization as well as high 0 dose and high disadvantaged populations that really need the service really needs the immunization to just prevent this vaccine preventable disease. So from the presentation I listened, the monitoring and evaluation, the routine monitoring and evaluation is very important that I shared, that I learned from scholars. I really appreciate. And also it's very important to have sustainable supervision. Just sustainable supportive supervision is very important for the lower level healthcare providers, and really it's very important to have a capacity building, especially in Ethiopia. There are health extension workers that is really working in prevention activities that may be the right part of to address this group also, in addition of my objective. And also it's really good to incorporate private health sectors to give immunization service rather than just leaving this to the government or public service, public healthcare projects only. So it is good. It is a really interesting session that I learned a lot how we can improve our immunization status here in Ethiopia. Yeah, thank you, Radat, and thank you, Francis.
All right, thank you very much. I know that some of you are, I'd like to ask you to do one last thing. So first of all, if you can go to the Telegram for the movement. So let me remind everyone, yes, and leave a message about sharing with colleagues, many of whom are not here, obviously. And tell them what you gain from this session, and leave a message. Yes, share with colleagues what you gained from attending this session. So I'll put that here. If you can do that. And then second, I would like to ask you to type yes into the chat if we can count on you being here on Thursday. So coming back, we have 2 experience sharing sessions, and we know some of you will be able to come back. Others will have daily duties that keep you from participating or connectivity issues. But let's build the momentum through these sessions. And so again, if you have not yet done so, go to Telegram and leave a message. Just tell colleagues what you gained from attending the session. It was useful, or you can just say, I learned a lot from sharing experience. Just put in a message in Telegram to raise the attentions of your colleagues, and put a yes if you are going to attend Thursday. Now, I will tell you that I will compile a list of all of those of you who said yes, and we'll look for you on Thursday when you come back. So I would like to see some. Let me share my Telegram window, and we'll be able to see live. So we'll be able to see where is the Telegram. Yes. Okay. So this is Telegram. So we should be able to see. Okay. Right now, only one person has left a comment. So if you can go to Telegram and leave a comment. All right. And this is not someone who's in the session. This is someone who's trying to join. If you can go to your Telegram app and leave a message for your colleagues so that they know they missed something that is useful and important that could help them, then please, yes, and if you intend to be back on Thursday, let us know. And if you're in touch with colleagues from the movement, or those, 2 things. One is, it is still possible to join the movement and to join the Action Plan Hackathon. I'm going to share 2 more things, as we're now the sort of maximum number of participants. One, I'm going to share the Word document. So you've also received this by email, but not everyone is able to follow. Okay, thank you, Precious. Precious just left a message saying experience sharing was very inspiring. So let me see if I can, so every time, yes, we can say it, of course, we can say we think this experience session is great, but it is far more powerful if you see a colleague saying that experience sharing was, as Precious did, or thank you, Abu Bakr Suleiman, saying, indeed, today's session is wonderful. Thank you very much. Professor Becky Tagbo says, I learned several innovative ideas. Daniel Ekwam says, it's been a great experience. And Daniel, I'm sorry we did not hear from you. Raul Bonifacio, the session was rich in discussion. Radiant Lauren, thank you. You just need to click on the link. Let me just put that link again, for those of you who missed it. But let's, building a movement means we're accountable to each other. We share with each other. So yes, and then just go to Telegram and let everybody know. There are, as you can see, there are how many people? I'm pretty sure it's like 3,000 subscribers who will see your messages, your encouragement, and saying, why should you on a Tuesday afternoon, a Tuesday evening, a Tuesday morning, why you should join this this session. All right, we're at the 60-minute mark. François, I'm going to ask for your closing reflections and comments. And again, we'll be sharing the recording for those of you who missed some of the session.
It's hard to summarize in just few words the richness of the sharing of experience, which varies from area with hard to reach, area with insecurity, areas where communities have not made vaccination a priority, the idea of prioritizing the efforts, the idea of linking the identification of 0 dose by the polio team, and sharing locally the vaccination. We heard it's a challenge in some other area of Pakistan, that you can only cover 20% of the 0 dose that way, that you need complementary strategy. We heard there is not one strategy that will fix the problem. I think I heard and read in the comment, I can agree more, we need to be sure that those will catch for the first time the 0 dose will receive the follow-up dose with a relevant strategy, because the mother comes only once initially to the hospital to deliver. I think it's the word of integration, which may be relevant particularly for population who have limited access to hospital health facility, and for them vaccinations may not be the priority. They suffer and they die from other life-threatening disease. So the word integration is important. The follow-up, the monitoring and the follow-up is very useful. We heard how to use as a contact point hospital delivery, private and maybe public and private, because the private sector is developing everywhere. And in some countries, the private sector may not immunize only the public sector. I think we heard really very interesting ideas that people have picked up. As one thing I would like to stress, which was in the chat, is antenatal care, even first visit, is sometimes extremely high in population, and those mothers may not bring their child for immunization. Access to antenatal care is sometimes higher than access to routine immunization for children. But those mothers will deliver, and if identified, you have a mapping of where the children will be delivered 9 months later, or a few months later, because they expected the delivery. So I read that it was captured on the chat, and this woman could be very helpful to be brief on the immunization and making sure the child receives the dose. Many women may attend antenatal care and their children never been immunized. So thank you, Reda, for this, and thank you to all participants for sharing a lot of innovative and very detailed, specific experience. Very useful, and I learned again this time. Over to you,
Reda. Thank you, François. A wonderful session, and thank you to all the contributors and the listeners. We know many of you, if you're here, are actively listening. I'm just showing for everyone has received the link to the action plan form. I'm also going to be sharing it here. I've just put it in. I shared the Word document as well. Let me share that again. In case you haven't gotten this, it's in your inbox. You just have to look for it. Some of the questions, such as if you filled out the full movement application, then yes, you have answered some of these questions, your priority challenge before. But 8 weeks into the movement, we expect that many of you, even if what you said 8 weeks ago, you now have some perspective, you have gained some perspective on it. And so this is an opportunity to revise and improve how you define your challenge, we shared this yesterday. Really make it specific, organize it by strategic priority, by key area of focus, define the goal of your action plan, explain why the goal is important. You work your way through the questionnaire. Be careful, because if you lose the connection, you will have to start over. Unfortunately, there is no way to save your action plan in progress. So you do have to do it in one sitting, which is why I encourage you to use the Word document. Prepare your responses in the Word document, but note, we do not receive action plans by email. You must use the online form that I'm sharing now. And you've received the link in your inbox, so you can find that. As you work your way through this, yes, François?
A little inside question that we have heard the challenge on the 0 dose shared by one of the participants. I think make sure when you prioritize your challenge that you have some evidence of your challenge priority. Using the data as it was shared by one participant on the 0 dose, having some data is very important, because this is a baseline from which you will monitor your progress over time with your corrective action. So whenever you can, you should look at your indicators and back up your priority challenge with data. This will be your baseline, and it will convince your supervisor that really spending your time on that challenge is really worth it to make a difference. Thank you.
Thanks, François. And the indicators come at the end. We do ask you to share the indicators that you know. So starting with, for your area of intervention, whether it's the entire country or specific, yes, let me see. So let me see if, if there are any questions about this in the chat. So I'll be sharing a tutorial, really going through the entire questionnaire, question by question, helping you, providing some guidance. But this is the quick overview. You can see we ask you to explain what type of environment you're in, and you can always say, if you don't know something, you don't need to fake it. You can say, it's not a bad thing. You're not making a mistake. Remember, we're not grading this. We're not asking you to peer review this. So, but this will give you, for example, if you don't know the size of your population, you do need to get this done by the 20th of May, but maybe you can ask a colleague and change your answer from a no to a yes. So you put in the size of the population, the number of outreach sessions, but there are actually two numbers: the number of sessions planned and then the numbers actually carried out. And for those of you who completed situation analysis, we asked you to submit a situation analysis report. At the time, we only asked you for outreach sessions planned. We realized that actually we need those two numbers. So as you can see, for those of you who are paying attention to the details, there are some distinctions. So please be careful about answering the questions. You'll see that in some cases, the devil is in the details, and what will make the difference between correctly understanding your situation and making a potentially fundamental mistake, making it very difficult or unlikely for your action plan to lead to the result that you are seeking to achieve. Sometimes comes down to the details. So you can see, again, if you don't know the antenatal coverage and you don't see how by May the 20th you're going to be able to answer this question, then just click no and skip it. We would rather know that you don't know than have you submit a number that is not the reality or that is not based in fact. And again, your action plan, remember, you receive it by email as soon as you submit the questionnaire. So the action plan is for your benefit. You are going to be the one using it. And we're going to discuss on Monday why and how collecting these indicators, being clear about what is the situation and what are the indicators in your context, in your area of intervention, how that is going to help you. So I hope that's helpful. I'll share the link one last time. All right, so Martin, who says, please, my file cannot open for me to read the instructions before starting my action plan. So it is a Word file. I've just shared it. Are you able to download it directly from Zoom? Otherwise, I would say it's an IT issue. I would urge you to check. Can you download it from here? I've just sent it, posted it again. And again, you'll be getting, for those of you who have been in the movement since March, you'll be receiving a specialized, personalized link showing you that will help you skip the first set of questions, asking you to tell us about your system level and your country and so on, because this information we already have. But starting with the challenge, we are asking you some questions again so that you can update and improve your answers this time around. I think that is it, unless there are any burning questions, but I don't see, other than Martin, I don't see anything in the chat. So Mariam, there is no template this time. You answer using the link that I shared, so it is different from what we did with situation analysis. So in this case, there is only the online questionnaire. We do share with you the Word file. It is not a template. It is just all of the questions you'll find in the questionnaire. Okay, great. So it may be better to download from your laptop rather than your phone. And I think that is it. As I said, this is a real work session, experience sharing session, no applause, no music, but I hope you will find it just as enriching, even though we know the emotion is an important part of the movement for Immunization Agenda 2030. Thank you very much. Look forward to seeing you on Thursday. And again, you can still invite colleagues to join the movement. If you think this is worth your time, think about the reasons why and share those with colleagues. Identify what is keeping them, what are the barriers to their joining the movement? Because if this movement does not grow, we will not be able to make progress, and we will not be credible as a voice of immunization staff from all systems levels working together to improve immunization. And those of you who are in this room, who on a Tuesday afternoon or evening or morning took the time out of your schedule to attend, to listen, to share, that makes you amazing. That makes you leaders of this movement. And it is your leadership that can and will already has made the difference. Thank you, and wishing you a pleasant morning, afternoon, and evening. I'm now going to unmute everyone so that we can hear each other.
Thank you. Thank you, Rada.
All of you.
Thank you, Rada. Thank you, Charlotte. Thank you for the wonderful presentation. Bye-bye.
See you next time.
Bye. Good to be here.
I couldn't find them, boo.
Bye. Bye, everyone.
Bye. It's been a pleasure.
Bye.
Bye. Bye. Bye. Thank you.
Bye.
Bye, everyone. Bye. Bye.
Bye bye. See you next time.
Bye.
Bye. Thank you.
Yeah. Bye.
Bye, everyone.